So in the lab, we have a 4-person team for every case. We have a physician and then 3 staff members. We have techs and nurses, and there has to be at least 1 nurse in the room to give medications and circulate the cases, meaning getting equipment, giving medicines, evaluating the patient, and making sure that they're comfortable. And we'll have 1 person monitor, that can be a tech or a nurse, and 1 person will scrub in with the physician and assist the physician at the table. That can also be a tech or a nurse. Okay, so over here we have a bunch of our catheters. These are diagnostic catheters. We put them in, we use them just to take pictures. We don't intervene, we don't fix any blockages through them. They're less traumatic to the patient's vessels. They're a little bit smaller diameter, and that's why we're not able to intervene through them, because they're not built very rugged for working through. These are guiding catheters. These are designed to work through. These are what you fix your blockages through. And they have different shapes because they have different purposes. Everybody's anatomy can be just a little bit different. There are basic catheters that fit most people with different sizes, with the same shape and different sizes. You can see subtle differences between the two. And then there's various shapes for different arteries. This one here is designed to fit into the right coronary artery. This one here is designed to fit into the left. All it is a shaped plastic tube. It's nothing fancy, with a big hollow lumen and a rigid outside. Through that we'll put our interventional wires, which are 14 thousandths of an inch in diameter. Those, like I said in the other video, work as a railroad track. Then we can put our balloons, our stents, and everything on top of it. We'll run the wire through the blockage, put the stent on there, inflate it inside of the blockage, and then take everything back out and leave the wire in place so we can continue working. Over here we have our sheets. These are the tubes that we use. They basically are big IVs, but they go into the artery or the vein, but typically we're working in arteries. They will hold our place. They have a valve on them so we can run our equipment through the device. And then we always have access to the patient's vessels. There are different ones for radial access. It has a much thinner body, and it's very, very slick because the radial artery is much smaller. So while it has the same inner diameter as a 6-French sheet that would typically go in the femoral, it's a lot more brittle because it's not designed to go through a patient's tissue. Down here, it's designed to just go right into the radial artery. Over here is our contrast. There's different strengths. The Omnipake is we use for people with normal kidney function because this stuff is poison for the kidneys. It will kill your kidneys, but it's the only way we can get the images we need. So we use the VisiPake for people who are lower kidney function, Omnipake for better kidney function, normal kidney function. We have other devices. This is a closure device. This device here, when we take that sheath out, we can put this device down. It has a suture. It goes inside of the body and sutures the hole we made in the vessel wall closed, so that patient won't bleed. They can be back on their feet sooner and there's less risk of a bleed. We have other devices too. This one is these two are both collagen plugs, different styles, different types. Both do their jobs well. That device goes into the vessel where the sheath was. This device here has a foot plate, holds its place, and then you push that plug down, and then it plugs the hole we made. The other one is the same idea without the foot plate. Then everything's out of the body except that little plug keeping that hole shut. So when the catheter is in place and it's engaged with the coronary artery, we'll fill it with contrast, which shows up on our x-ray, and you can see it filling the vessels. This picture here is a pretty normal LAD, normal circumflex coming off the top. But it's very important we take multiple angles because sometimes blockages aren't always showing on every single picture. So we go through, we move the C-arm and take different angles so we can accentuate different vessels and open them up different ways to find blockages. I don't have anything else. So when we're injecting the dye, we're looking for anywhere where there's a narrowing, anywhere that the dye is not filling. So right here you can see where the dye's filling around this tight spot. The rest of the vessel should look just like this, nice and smooth and big and healthy. There's plaque built up right in here in this area, which is causing a restriction of blood flow. Somebody's cardiac tissue isn't getting blood flow it needs. So that's what we look to fix. And here you can see we have our guiding catheter down. We have a wire which works like a track running through the blockage. And this right here is a balloon inflating. We fill the balloon with contrast so we can make sure that everything expands properly and is well opposed into the vessel wall. In your next picture, you'll see the result. There's a stent there. Now, we put a stent in. So you can see the blood flow is coming through there now. The vessel looks much better. And he goes through with the balloon, make sure that it's well expanded, make sure there's no issues with the stent after. And we'll go to our final shots. Great blood flow going back through the vessel. So the first thing we'll show you is the C-arm. This is our fluoroscopy tube, our X-ray tube. The tube itself is actually underneath the table. It shoots the radiation up through the patient, and this is the image intensifier. That's where the radiation comes through. It's where our images come from. They come off right here on this screen. And we can watch in real time. It's like having an X-ray camera. We can watch in real time during the procedure. This is just the table. It's got a nice uncomfortable mat in the patient's hate. We have the ability to move the table around, so whenever we're trying to find whatever we're looking for on here, the tube's stationary, we move the patient where we want him to go. We have a whole bunch of controls down here. Each one does something different. This one moves the table up and down. We can move the image intensifier closer or further from the patient. And this is how we get the different angles we need. We have a joystick, we can move it wherever we need to. And then there's all kinds of other options here. We can magnify or demagnify our image based on what we need. We can take a fluoroscopy run and then save that. We can adjust our collimation, meaning like how much radiation the patient's getting, the size of our image. And there's all kinds of options for imaging here, depending on what the case calls for. Down here, this is how we operate the fluoroscopy or the C-arm during the procedure. There are 3 pedals on it. This one runs basic fluoroscopy. That's our camera that works real time. The middle is called a cine pedal. It uses a much higher dose of radiation, up to 10 times more or 20 times more. But it gets very, very crystal clear images. You use it for short bursts so you can get one good shot. This is your workhorse pedal where you run 95% of your procedure through. And this one just dims the lights so we can see what we're looking at on the screen. All of this gets covered when the patient's on the table. We have our monitoring equipment, which we can follow everything that's going on with the patient's EKG up here, their blood pressure, their oxygen level, heart rate, and then we have a pressure line set up to our system where we can watch their aortic pressure as we're working. This screen, we can put an image up here that'll hold up there, so whenever we're working, if we need a reference image, it stays right here. In the other lab, we actually have a system here where we do different tests that we might need to evaluate lesions or blockages during the procedure. So what we have here is a simulation of a radial access intervention. We have our glide sheet, the thinner sheet that's designed for the radial artery. Through that, we have our guiding catheter. This is that more rigid, stiff catheter with the bigger internal lumens we can put our equipment through. And since we don't have a patient here, we set it up to simulate going up the radial artery, down the subclavian, into the aortic arch, down into the root, and hooked into the coronary artery. Right here, already down, is a interventional guide wire. That's the part that acts like the track for us. and this is simulating going through a right coronary artery. So we have a stent loaded on here already, and I'll show you. It just goes up the guiding catheter. Keep our equipment in place here, and then it comes out of the end of the guide, and then we can track it down that vessel, in theory, and then put it wherever it is. Inject contrast through here. We'll have a kit set up where we have our syringe, and we can inject contrast right through the catheter while we're working, and we can see exactly where that thing is before we deploy it and put it in that person's body. There's a balloon underneath the stent. The stent's wrapped tightly around the balloon. We inflate that balloon with contrast so we can watch it expand. That stent gets pushed into the vessel wall, opens that blockage up, and then we retract that contrast back out. It sucks it out, and we can take the balloon out and stent stays in place. And then, once we're done with the procedure, you just pull the wire out, take a picture, make sure everything looks good, and then take the catheter out and we're done. And then we have to close our access site. Showing you here is our catheter. Like I said, this is simulating the right coronary artery, where it goes around the inferior portion of the heart. And this is our stent. There's two markers here, a distal marker and a proximal marker, so you know exactly where that balloon's gonna inflate to its maximum diameter. What you see here that's dark is the stent itself crimped tightly around that balloon. In the other video, you can see what a stent looks like once it's deployed inside of an actual vessel. And this is when we would inject contrast down the vessel, fill it, make sure that we're lined up properly, and then we go up on the device to whatever pressure we need to get it exactly how big we need it. So, when the radial sheet's in place, you have to picture it like this. The rest of it's inside of the radial artery. This part's out for us to access through and put our equipment through. When it's time for the case to be over and it's time to take it out, we're going to put a band on. This band has an air bladder on it that you inflate with air. You wrap the Velcro around, inflate it with air, and you can see it inflating, where it puts a lot of pressure on that artery so the patient doesn't bleed. So, we're going to center it over the access site. Then, put a little bit of pressure. We're going to slide the sheath out, and as it comes out, we're going to put some pressure on there, fill that balloon up, make sure it's not bleeding. Then, slowly dial back the pressure. Eventually, you'll see blood start to flash from that artery, just a little spot here and there every time the heart beats. Then put a couple cc's of air back in, double check it, make sure everything's working fine, make sure the patient's not bleeding. We're gonna move their arm because no matter how many times you tell them, they're gonna move their arm as soon as you quit touching them. Make sure that that's not gonna affect it, make sure they're not gonna bleed. And then we'll know exactly how much air we put in. We'll chart that and document it and give it off on our report when we hand the patient off. And this will stay here until the patient's blood thinners wear off, until the patient's stable enough to have it off, and this will come off before the end of the day.